Okay, so we're finally here with the much requested NBME 24 explanations. It's been a little slow because it took a very long time to even get the exam. I wanted to have it in like a very nice and clear format so that it's not like blurry and whatnot. Other than that though, let's make this wide. Nice and big. Alright, so other than finding this in the right format so that it's clear and legible, it's just been really, it's hard to get yourself to really do an exam and write out explanations while fasting. It's already hard as it is to begin with, definitely even harder while fasting. So there's a big part in that, but I was able to get through the first 25 questions yesterday, so I'm going to go ahead and do this part 1 video where I'll get through questions 1 to 25 now. I did get to skim through most of NBME 24, and I haven't seen all the questions yet, but for the first 25 questions I have here, I would definitely say they were pretty easy, pretty straightforward, well worded. Nothing insane so far, but it's only 25, so there's still 175 questions left to look at. But these were good 25 questions. So far, I like the test. All 25 of these questions are a good way to gauge if you're ready for step 1, because when you read these questions, you should have an immediate thinking of what's happening, what you need to know, and what knowledge will help you answer the question. If you're lacking in one of those things, that's when you know that you need to go back and revise that topic and get better at actually solving problems that ask questions on that. So let's dive right into it. So number 1 over here, 40-year-old woman with a 25-year history of type 1 diabetes has a serum creatinine concentration of 2.5, which is obviously very high. A creatinine clearance test is ordered to determine the glomerular filtration rate. This test is limited compared to an inulin clearance test because of which of the following properties of creatinine. So they're asking you to compare creatinine with inulin. And you have to remember that one section of GFR and inulin and PAH and all of that where they talk about it. They only had 4 answer choices here, which definitely helps because it's 25% chance of even guessing wildly. So the first one says actively pumped into the DCT. Now, none of these guys are really actively pumped into the DCT, so A should actually be an answer choice you can immediately cancel out. Crosses freely into the loop of Henle, reabsorbed into the collecting duct, secreted by the proximal tubule. Now, the loop of Henle, which is in the medulla of the kidney, is also a part where not much of these things cross freely. So you want to be able to cancel out B also, leaving you with just between C and D. And if you were able to cancel out A and B, then you have a 50-50 chance of choosing correctly between C and D, where D is the correct answer. So GFR is generally calculated with clearance of inulin, which is why they're comparing it to inulin. Normal GFR should be 100 milliliters per minute. Creatinine clearance always overestimates GFR. If you can remember that sentence, if you can remember that statement, then you'll be able to answer this question without a problem. So creatinine clearance overestimates GFR because creatinine actually gets excreted. Now, these terms are where understanding kind of falters. So you want to make sure you have a good understanding of what it means to be filtered, excreted, secreted, all of that stuff. So coming back to here in first aid, you can see all that stuff we're talking about right now, the GFR, and how creatinine actually is an approximate measure but overestimates it. So why is that? So if we go to where they talk about, this page right here where they actually have arrows showing you filtration, reabsorption, and secretion, and then of course the final stuff that all gets urinated out, excretion. Everything that came in from the afferent arteriole, right, will be filtered. Either things are going to go back into the blood vessel or come out of it and then go into this yellow space, which is basically going to be part of your urine. Everything that came back into the urinary stuff, which is the lumen, will then pass down in the nephron. Now, within the nephron, of course, there's this area right here, the peritubular capillary, where things can either be reabsorbed, so it's going to be taken out of the urine and put back into your blood, or more is secreted. So that means that you're going to take it out of your blood and put it into the urine. Creatinine is something that, going back up here, creatinine clearance is an overestimate because creatinine is actually moderately secreted, right? It's moderately secreted. So what does that do? So that means that, let's say right here during the filtration process, let's just put a number to it. Let's say 1 milligram of creatinine was actually filtered. Then over here, you might secrete another 0.1 milligram of creatinine, making the total excreted amount 1.1, right? So everything that was filtered was what was helping you estimate the GFR, the filtration rate. Then when you added more into it, or if you took anything out of it, that would either over or underestimate the amount of GFR, right? It's the calculation of GFR. And that's really all there was to it. So more of it is secreted, and that was the key word you were looking for, and only one answer choice has that secretion aspect of things, and that's it, right? So this was a renal question regarding GFR. Pretty straightforward, nothing crazy there. Number 2, a 10-year-old boy who was adopted from the Democratic Republic of Congo 2 weeks ago is brought to the physician for an initial examination. He appears slim, has thin extremities, and is in no distress. His temperature is high, so this is a microbiology question. Pulse is 100 per minute, respiration is at 20, blood pressure is okay. The lungs are clear, heart sounds are fine, abdomen is soft and fine too, no hepatosplenomegaly. The only problem is this stuff, right? So far, everything we saw was just a lot of information to deter you and confuse you, but one thing was clear: he has fever, he must have infection. Then the only actual problem is this stuff. They're finding 4.5 millimeter firm, non-tender nodules, 2 that are over the right iliac crest, 1 on the left thigh, and 1 on the left knee, right? So random 0.5 millimeter non-tender nodules. Examination of a skin snip from one of the nodules shows microfilariae, and that was the giveaway for the answer. Which of the following is the most likely vector of this patient's infection? So you know you're talking about microfilariae, and at that point you can kind of cancel out some answer choices like the Culex mosquito and the reduvid bug. Those are irrelevant to microfilariae in that entire chapter of the nematodes and all those different filariaceous things. Now, if you couldn't remember the lesions they're talking about, the non-tender 0.5 millimeter nodules, if you can't remember that, then it became a little difficult. Now, body louse is another one that, the body louse and the ixodes tick. Now, ixodes tick, you should remember all the things that it causes. The ixodes tick is responsible for babesiosis. It was also responsible for the Robin Hood, whatever that disease was. My recall really sucks when I'm fasting, so I can't recall anything. But there's only 2 things that ixodes tick is responsible for, and that is irrelevant to this question too, because he doesn't have either of those diseases. That leaves you really with just the black fly, and then of course if you're a little confused about the body loss part, then that. But this was just the black fly. So this is onchocercal volvulus. This is a pretty different presentation. Usually the black fly will be about river blindness and stuff like that, but this one was just about the actual nodules that it causes, and it's in first aid too. So let's go back to page 164. Let's see. Right here, so onchocerca, skin changes, loss of elastic fibers, river blindness, which is usually what the question is about. And all you need to remember is all the black things it does. So black flies, black skin, black sight, right? And that's something that you definitely want to remember, because on this page, almost all of these are actually high yield, in the sense that any of them are fair game and pretty equally tested. Borrelia, thank you. Right, pretty equally tested. So you want to make sure you remember the key, tiny one thing that helps that one bug, whatever it might be, differentiate from the others. Another one that's very commonly tested in NBME was the Loa Loa, right? So they like throwing in these random flies, because when you might see mango fly on an answer choice, and you might be like, I don't remember what that was related to. And so our guy has the black skin nodules, right? And it's not an allergic reaction that he's having. Those are probably not only just infection, but also the sites where the black fly might have actually inoculated the bug into him, right? So these answer choices were not so hard to pick off, because a lot of these, especially reduvid bug and ixodes, are answer choices that you should know exactly what they're related to, and this presentation was not for any of those things they're related to. It's not a bad question, but yes, this was microbiology. Number 3 here is a 3-year-old girl brought to the physician for a well-child exam. She's had a flat purplish lesion that measures 2.1 centimeters in diameter on the right side of her face since birth. The lesion shows large cavernous vascular channels, so it's a lot of blood vessels in there. Which of the following is the most likely outcome of the lesion? Right, so this specific thing that's in the question is actually not in first aid. It's something called nevus simplex, but what you could do is understand that this looks like it's something similar to a strawberry hemangioma. Now, strawberry, you want to remember the strawberry shortcake. It's like a cartoon thing. It's a doll. The strawberry hemangioma is what occurs in kids, whereas the cherry one occurs in adults, right? The cherry one is a whole different scenario, but the strawberry hemangioma, the UWorld had a very notorious question where they tested you on what would be the end result, and the strawberry hemangioma, it grows and then regresses, and that was an answer choice that you had to pick in that UWorld question, because that same UWorld question also had another answer choice saying it'll just go away, but you have to be more specific. It grows and then goes away. Now this baby doesn't have a strawberry hemangioma because this is flat. A strawberry hemangioma is not flat. So let's go back and take a look at that real quick. So so here is just histology of nevi. This is a different kind of, there's junctional nevus, compound nevus, intradermal nevus. There was a whole UWorld question about these kinds of different kinds of nevi. Nevi generally tend to be the ones that are flat. Those are the things that are usually flat. The baby in our question doesn't have any of these, but it was worth glancing at this. And then, of course, when you go down to where they finally talk about strawberry and cherry hemangioma and all that, you can see this, where is it? The strawberry one. You see, this is exactly the kind of scenario the baby has in our question, right? Something on the face, except the one in the question is flat, right? But it's not usually flat, the strawberry hemangiomas. So what our child has in this question is a nevus simplex. Either way, though, if you did think that it's a strawberry hemangioma, you would still pick the correct answer because you would just pick answer choice E, spontaneous regression. Right, which was correct for this also, the nevus simplex. It is not going to have local invasion, which is basically the same as malignant degeneration. It's not going to have necrosis and scarring, and it's definitely not going to lead to a concurrent congenital heart disease. All of those answer choices, in my opinion, when you get more and more experience, you start having better opinions on answer choices. Those other answer choices were completely irrelevant to anything I would ever want to pick for such a patient. Okay, this was a pretty interesting question. So this is sort of biochemistry, sort of endocrine. At 2 a.m. after sleeping for 5 hours, a 32-year-old man with type 2 diabetes has a decrease in serum glucose concentration to 37. In response to the hypoglycemia, cortisol secreted by the adrenal gland induces the synthesis of which of the following enzymes in the adrenal medulla? So this question actually was tailored in such a way that would help you pick the answer, because they're directly leading you to an enzyme in the adrenal medulla, right? So you want to think of all the things that are made in the adrenal medulla, and that's basically your catecholamines, your epinephrine, norepinephrine. So you look at all your answer choices: acetyl-CoA carboxylase, homocysteine methyltransferase. All of these enzymes that are listed here, for the most part, should ring a bell for you. You should, every time you ever see an enzyme, once you've done a good job with biochemistry, and my biochem videos are extremely famous. Once you are done with biochemistry, you should have a good understanding in such a way that when you see the name of an enzyme, you should be able to associate it to a specific process, whether it be ketosis, gluconeogenesis, glycolysis, lipid metabolism, whatever it's related to. So when you see acetyl-CoA carboxylase, this is actually the main enzyme for fatty acid synthesis. Now, in first aid, it's not exactly labeled. So let me see what's on page 83. In first aid, they didn't exactly label that that enzyme, but I did label it in my videos. So in my book, I have that enzyme titled out because I don't know why it's not actually labeled, but it should have been. This one right here. All right, so acetyl-CoA carboxylase is the one that takes acetyl-CoA and makes malonyl-CoA, and that's really significant because malonyl-CoA is also the same substrate that goes back and inhibits fatty acid degradation, right? So when you're making fatty acids, you shouldn't be breaking it too. And since malonyl-CoA is so important, this is an important enzyme worth remembering. So acetyl-CoA carboxylase, that's choice A, is related to fatty acid synthesis, and that is irrelevant for our question. Then you have homocysteine methyltransferase, which should ring a bell, of course, for all the homocystinuria things, and this isn't a question about that. Choice C, methionine adenosyl transferase, and choice E, PMNT, PNMT, excuse me, are both relevant acid choices to things that help make epinephrine and norepinephrine. Where do you see them? So they're actually on page 83. So let's go back to that. Pretty important page over here, right, with the catecholamine synthesis and tyrosine catabolism. Now, everyone generally tends to remember this upper part over here, up to dopamine. And of course, dopamine beta hydroxylase is the enzyme that uses vitamin C to break dopamine into norepinephrine. It's after here that this bottom part people usually mistakenly forget about. Right? So no one really tends to remember this middle section here. And then everyone obviously remembers all the different urinary things you would find in a patient who might have like pheochromocytoma. Right? They're going to have high HVA and NBME. This middle section here is what the other two answer choices are about. So there's SAM, and then there's this. Those are your two answer choices that are given in the question. So right here, this methionine adenosine transferase thing is basically the guy that makes SAM. And then this one over here is the enzyme that is directly upregulated by cortisol. And that's what the question is about. You can see how cortisol upregulates PNMT function, and you make more epinephrine. Okay, so this is something that's really significant because UWorld and even First Aid itself, there are many questions related to what happens in hunger, what happens when you're fasting, what happens when you have a extensive use of metabolic fuels, right? Everything runs out. So the physiologic defenses against hypoglycemia are often tested. This right here is actually a UWorld question where they were testing you and the answer was cortisol. Right? It was about an old lady who fell into the bathroom or something, and she had an injury and she didn't eat for quite a while because she fell and she couldn't get up. What managed to keep her glucose levels pretty good, and they wanted an intracellular receptor answer choice. So this was just about cortisol, right? I kept the screenshot the way it was because I actually picked glucagon as an answer choice and I was wrong. But I learned that it's cortisol, and then of course that's what this is all about. Learning about cortisol, learning about epinephrine. These two things are what's being tested because of course all medical students have a pretty good knowledge of insulin and glucagon by the time they get through and prepared for step one. So it's the cortisol and the epinephrine stuff that newer questions are leaning more towards, right? So cortisol works with PNMT to upregulate epinephrine formation, and that's going to go help manage your glucose levels to normal. So I put that image here too. Right? Nothing insanely crazy, but definitely could be something you might have never seen before. Right? But doable because you should be able to cancel out answer choices that you know are not related to the adrenal medulla, are not related to norepinephrine and epinephrine formation. The only enzyme you might have never seen is this one right here, methylmalonyl-CoA racemase. Now, because you've never seen it and it doesn't really seem to be fitting what's happening, you can cancel out answer choices like that too, and this is one that you can cancel out. Now, it's a tricky thing to do because, of course, oftentimes there could also be an answer choice you've never seen before, but that was the correct answer. In those kinds of questions, all the other answer choices are usually stuff you have seen, and you should be able to cancel them out. This enzyme, the racemase, is an enzyme that you've never heard of. It's an epimerase involved in fatty acid and amino acid breakdown, which is pretty clear from the methylmalonyl aspect, right? Usually these things are organic acid related stuff, methylmalonyl, so it's irrelevant for the adrenal medulla. Question number 5 was an ethics type of question. But again, I read the question and it didn't take me any time or any confusion in figuring out what must be happening. So Rita said, random question, but do you have a way of memorizing the first aid page in pathology that talks about where different cancers metastasize to? I do. I've definitely spoken about that in one of my videos, but just shoot me a quick email. I'll just send you the tips on that. And then I'm taking Form 24 next week. Sure, okay, so you definitely want to not watch this right now and then come back and revise once you're done with it. Okay, so 25-year-old woman takes an overdose of barbiturates and is found unresponsive several hours later by her husband. Could be a suicide attempt, could be something else. She's comatose, undergoes endotracheal intubation and placement on a mechanical ventilator. 3 weeks later, she opens her eyes spontaneously and has roving conjugate eye movements. She has no purposeful responses to stimuli. Brainstem reflexes remain intact. EEG is diffusely slow without evidence of any cortical reactivity. The patient has signed a living will and consistent with his directives, her husband requests that mechanical ventilation be discontinued. Now, what they're trying to make this question look like is that the husband is killing her, right? Did she really overdose, or did he make her take it, or is she just that depressed, blah, blah, blah. But the main thing to look out for in this question is the fact that the patient did sign a living will, which is really rare for a 25-year-old, right? Why would a 25-year-old have a signed living will? And then consistent with those directives, the husband is ordering that the mechanical ventilation be discontinued, which kind of makes sense because at this point, it does look like the patient is theoretically dead, right? They're just being kept alive by the mechanical ventilation, but there's no brain function. Even the opening of the eyes was just some kind of neuronal activity that was occurring, but not that the patient came to wake up and come out of the coma or anything like that. So not that at all. Now, which of the following is the most appropriate next step by you as the physician in patient care? So you look at all your answer choices, but you know nothing wrong is happening in this question. Whatever is happening is perfectly fine, and since it's consistent with the directives, it must be answer choice B, extubate the patient and discontinue mechanical ventilation. Make no attempt to do cardiopulmonary resuscitation in case of any cardiac or respiratory failure. Basically, you're discontinuing their life because that's the point of discontinuing mechanical ventilation. It's not like discontinuing mechanical ventilation would have just saved her and made her okay again, right? So the other answer choices really don't make sense. You almost never refer to the hospital ethics committee. That only occurs in extreme cases where it's just impossible to come with an answer and discussion on the spot. Obtaining a court order is irrelevant too because you're following directives that are in a signed living will already. The other choices A and C are irrelevant. Right? Intubation and all of that doesn't matter. The patient doesn't have a DNI or DNR. Do not intubate, do not resuscitate, because she's clearly been intubated, and she probably doesn't have a DNR either. So resuscitation is something that can be done. However, the reason you were discontinuing mechanical ventilation is because you want the patient to just die. There's no reason to keep the patient alive by force. This was a neuro question about the anatomy of CSF flow. Very interestingly worded, but again, definitely in my opinion was an easy question based off of the experience you have, right? So when I say something is easy, it doesn't mean that it's definitely easy. It just means that after you've seen enough of things related to it, you should have a pretty good idea of what's happening. So this was a 63-year-old woman undergoing operative repair of a leaking berry aneurysm in the circle of Willis. 2 days later, a CT scan of the head shows a widening of the subarachnoid space. Which of the following changes in CSF is most likely cause of this finding? Right, so you look at your answer choices. Decreased absorption by the choroid plexus. Okay, that answer choice immediately doesn't make sense because the choroid plexus is what makes CSF, not reabsorb it. So you cancel that out. B was the correct answer, so we'll come back to that. Decreased movement through the cerebral aqueduct. Decreased movement through the cerebral aqueduct isn't being mentioned in the CT scan, so it doesn't look like the patient has some kind of obstructive hydrocephalus, so that can't be correct. Increased absorption by the choroid plexus. Again, in answer choice you can cancel because A and D are both talking about choroid plexus doing something that it doesn't do. F is actually correct in the sense that the choroid plexus does produce CSF, but there's no reason for it to be increased. So you cancel out that too. This just really leaves you with B and E. And E says increased movement through the arachnoid villi, which if you had, then if there was increased movement through the arachnoid villi, then there probably would not be any level of widening, right? So this patient has a communicating hydrocephalus, which means there's no blockade anywhere. And that's evident by the fact that there's no obstruction. In the CT scan, they're just seeing a widening of the subarachnoid space. This is most likely because the arachnoid granulations are not absorbing CSF. So you can see in this picture, you have random arachnoid granulations. Those are the spots that reabsorb CSF, right? And then it's going to be sent into your blood supply. So blood that she's leaking from her circle of Willis, that blood is inflammatory. Inflammatory things, and then of course meningitis and stuff like that, all of that can damage your arachnoid granulations and you will not be able to reabsorb CSF. Right? The arachnoid granulations reabsorb CSF and send it to the dural venous sinuses, which then go empty into the internal jugular vein. right? And all these are things that are discussed in first aid. So 570 and 571, let's take a look. Right, so this is right here your hydrocephalus stuff, right? You have communicating versus non-communicating. Non-communicating is some kind of structural blockage, and depending on, so wherever the blockade occurs, stuff before that blockade usually ends up expanding, right? Our patient didn't have any of expansion like that. Our patient had a more universal expansion of the whole subarachnoid space, and that's different. So that's going to be your communicating hydrocephalus, usually because of arachnoid granulations not working correctly, either after meningitis, it could also be after some really bad head trauma, and then of course in our case, our patient just has inflammation, because blood is inflammatory. Remember, arterial blood, it's inflammatory. Anywhere you have blood leakage, it is going to cause inflammation, and this wasn't so bad of an answer choice to pick, so totally doable. Mohammed, do you suggest BMB? Well, I don't really want to go off topic of the NBME explanation stuff, but you can always feel free to ask questions of any kind other than the NBME stuff in my emails if you want to, so shoot me an email. Overall, though, I don't really have much I can say about BMB videos. Kaplan I'm not a fan of, so I would never suggest anyone to do Kaplan. And that's about it. Alright, let's go on to number 7. So this one here was a pretty, okay, yeah, this was your acid-base renal question. So here, 23-year-old woman is brought to the emergency department because of shortness of breath for 2 weeks. Respirations are 28 per minute. Physical exam shows nothing wrong. Then you look at your labs, and the labs are kind of giving away the fact that the arterial pH is a little low, right? Should be between 7.35 and 7.45. This is lower, so that's acidemia. They give you urine values of things too, but there really isn't much to do with that. Then they want you to answer which of the following is the most likely diagnosis, right? So this is some kind of acidosis, and when it comes to these acidosis things, you have your mud piles, and with mud piles, you want to make sure you remember that you have to search for that the anion gap. And this patient, if you calculate it, this patient has a non-anion gap metabolic acidosis, right? So for the anion gap, you would just do sodium, which is 135, minus chloride and bicarb, which is 125. So the anion gap here is just 10, which is not more than 12. So this is not a anion gap metabolic acidosis. Things that cause anion gap are like lactic acidosis, because there's more lactate, which is an anion, right? Diabetic ketoacidosis, that's also part of the mud piles. So you cancel out all the answer choices that are related to mud piles, and you get rid of A, C, D, and F. Ketoacidosis, lactic acidosis, and salicylate poisoning, which is also going to create more anions. Now, renal tubular acidosis does not present like this. Renal tubular acidosis does not lead to any of this stuff. Then you have Crohn's disease, and of course, sorry, wait, what am I saying? I meant to say Crohn's disease. Crohn's disease does not present like this. It does not have to do with any of this stuff, right? Crohn's disease is an entire systemic disease as well as a disease of the intestinal area. It affects your entire body. Unlike ulcerative colitis, which is just a colitis, it only affects the intestines. Doesn't really have many systemic manifestations. Crohn's disease has systemic manifestations in the entire body. This patient is coming in just fine. She only has one complaint, which is a shortness of breath. Could be a cardiovascular thing, could be something else, right? So you can confidently say it's not going to be Crohn's disease and just move on. Now, the other thing that helps you understand it's not Crohn's disease is you have to remember all irritable bowel diseases, both of them, the Crohn and ulcerative colitis, they're going to have reduced sodium and chloride absorption and increased potassium secretion. This is something that's not mentioned in the book, but if you've done enough questions on those topics, or if you've done your rotations where you actually learn something, and that's pretty rare too, then at that point is where you start seeing that this knowledge starts kicking in. And our patient doesn't have problems in that area, right? The sodium and potassium, they're okay. There's nothing wrong with them. So Crohn's disease didn't really fit her serum analysis either. So that only left you with one answer choice, renal tubular acidosis. That had to be it, and that was it. You would pick it, you would just move on. So if we go back to first aid, right here is where, this page I have a really good video on, because when I do renal and I talk about the acid-base physiology, I go really in depth into it, helping you figure out what you're supposed to do so that you never have a problem where you get a question like, any of these things, where you get a question about, oh, X, Y, and Z is happening with this patient, well, what must be causing it? Oftentimes for me, in the beginning when I was new to these things, I would have a panic basically when I would ever see an acid-base physiology question, because I would have no idea. I would know there's some kind of, the easiest thing to figure out is it acidosis or alkalosis, but then I would have extreme trouble figuring out what kind of, is it metabolic or respiratory, what's the thing, what's the mechanism that's actually causing it. Those are things you develop over time, because you can't actually pick them until you actually know how each one of these things works. Each one of these things, you have to know how they work, what they do, and then you'll be able to associate them to the right part of the chart immediately, right? So if you don't know what methanol can do, what uremia can do, and I've listed some of them out over here, right? What an airway obstruction might do, or what salicylase can do versus early, and the difference between early salicylase and late salicylase is a big deal that gets tested pretty often, right? Early salicylate poisoning causes respiratory alkalosis, but later on it causes metabolic acidosis. You got to make sure you know that. And then, of course, it gets extremely hard when you have mixed things, right? Concomitant respiratory acidosis or whatever. You want to be able to do enough practice questions and have a good mastery of this table so that you can talk about all of this without the book in front of you, right? That's what you want to get at. Watching more and more videos about it can help you and, can teach you things, but until you can't talk about it by yourself, you don't know it. That's something that I'm pretty firm about. And the more practice questions you do, the more you get to analyze things and see how it's all working out. And so it's a very high yield, extremely high yield stuff. Very important to make sure you have a good understanding of all the different things that are on that page. Now, right after that page, and this is why I always tell everyone, when you're doing UWorld questions and you're practicing stuff, go and cheat. And by that I mean pick the answer choice you think is the correct answer, then go back to first aid and check. So if you think the answer is C or something, that's great. Now go back and check. The more times you revisit first aid, you get to make a connection between various things that are on different pages and how they're related to each other. So you can see right after acid-base physiology, they're now delving into renal tubular acidosis, which was the case for our question. Right now, we don't necessarily know exactly which one our patient has, whether it's type 1, 2, or 4, but it's definitely not 4 actually, because 4 would have decreased aldosterone production. So it's between type 1 or 2. Now, this is another topic, right? When I say master topics, this is another topic. Any topic is something that's listed like this, in this bold, these are all topics. So renal tubular acidosis is a topic that you want to make sure you spend some time on whatever day you're doing renal, right? As you're going through renal, you want to make sure you stop here too. Once you're done mastering acid-base physiology, stop here and memorize these guys, because these are actually not so bad. They're not that high yield either, but they're pretty important. They're doable, they're easy to understand. You just got to give it a little time. Nothing extremely complex is happening here, right? But this is what our patient is going through, just the renal tubular acidosis. Nothing else was given for our patient, so you don't really need to worry about anything else. And all the other answer choices just got canceled by not being an anion gap. This is also renal. So this one says, I like this question because I actually spent a lot of time not just teaching this, but also understanding it before I could even teach it. A 30-year-old woman comes to the physician because of a 2-week history of right flank pain. Her blood pressure is super high. Physical exam shows a 7 centimeter mass that is palpated on the right side of the abdomen. Could be something adrenal. CT scan shows a mass in the retroperitoneal space on the right side that is compressing the renal artery. Right, so retroperitoneal, one of the sad pucker things. If the perfusion pressure to the affected kidney is decreased, but glomerular filtration rate and renal plasma flow remain unchanged, which of the following mechanisms mediates the autoregulation in the renal arterioles in this patient? Now, autoregulation is something that's discussed in the first system you do in first aid, which is in cardiovascular. So, autoregulation for all different parts of the body are different, but in general, they all do the same thing except for the lungs, right? The lungs are the only one that have a different autoregulation. If there's a part of your lung that isn't getting enough oxygen, you actually stop sending blood there, right? Because the function of the lung is based off of sending blood to places that have oxygen so you can pick the oxygen up. So the lungs are different, but everywhere else, works the same. You have a place that doesn't get enough oxygen, you send more blood there to bring oxygen to it. The main thing they told you here, you need to make sure you understand it. So they tell you here that the perfusion pressure to the affected kidney is decreased, right? Perfusion pressure is decreased. So you can kind of think of that as perfusion is decreased. Less blood is going to that one kidney, maybe because the mass is, and they even told you, because the mass is compressing the renal artery, right? So right here. Now, they want something to occur where GFR and RPF remain unchanged. How do you do that? You look at all your answer choices. Decrease afferent and efferent arterial resistance, decrease afferent or decrease efferent arterial resistance. So A, B, and C are all doing the same thing. They're decreasing blood pressure. Decreasing the resistance means that more blood is going to be going through those guys. And then choices D and E, D says increase both of them or increase just the afferent. So now you look at all your answer choices and you try to figure out what's happening. Depending on your knowledge of this stuff, you either know, what the difference between those answer choices is, or you have no idea. Now, this page is where they talk about some changes in glomerular dynamics. I added more to it than what first aid had in itself. You need to make sure you understand what it means when you dilate either one of these things. What's going to occur? So, for example, if you dilate the afferent arteriole, right? So if you dilate the afferent arteriole right now, maybe, let's just say one arrow is a certain volume, and if I add more arrows, that's more volume. If you dilate the afferent arteriole, of course, more stuff is going to come in, right? More blood will be coming in, and that means more blood will be staying here. And if you don't dilate the efferent, it's going to stay here, and that's going to increase filtration. So that's going to increase GFR, right? That's going to increase your GFR. Here the correct answer was B, just decreasing afferent arterial resistance, but we'll come back to that. So if you just decrease only the afferent arterial, decrease the afferent and efferent arterial, then what happens? If you decrease afferent arterial and efferent arterial resistance, this means this is also going to vasodilate. So if 3 arrows are coming in, it's going to flow through really quickly, and 3 arrows are going to go out, right? And that's going to be a bunch of filtration. In that case scenario, answer choice A, decreasing both resistances, meaning vasodilating both of them. If you do that, you're going to increase your filtration. You're going to increase filtration because more stuff is actually passing. You're also going to increase renal plasma flow because, again, more stuff is passing. Right? You don't want to do that. If you only decrease the efferent arterial resistance, then you slow down the exit. You slow down the exit. The longer things remain here, the more filtration will occur. You don't want that either. Okay? So the only answer choice that you could possibly pick was actually answer choice Z. C, decreasing B, decreasing afferent arteriolar resistance. Why? Because, as we already saw, this is kind of compressed. When they say that the renal artery is compressed, right, compressing renal artery, it basically means that this is already kind of compressed. This has been tightened up already. So if you untighten it, nothing would change. You would basically be canceling out the tightening that's already been done on it. That's all that's happening. Generally speaking, right, if there was no compression on the renal artery, generally speaking, if you vasodilate here by decreasing the afferent pressure, then yes, more stuff would be coming in, and you would have more GFR, more renal plasma flow, regardless of anything else. Renal plasma flow is more so affected by the efferent, the exit. If flow is going to slow down, it'll only be because there's constriction here. If renal plasma flow is going to increase, it'll be because this was dilated. All right. Now, of course, there's memorization mnemonics, right? You have your NSAIDs, the prostaglandins, right? Prostaglandins preferentially dilate afferent arteriole. You remember that with the PDA, right? PDA is prostaglandins dilate afferent. So anyone that's taking NSAIDs no longer does this dilation, and NSAIDs can be problematic for the kidney. On the other hand, you have your efferent arteriole, ACE. ACE in itself is a mnemonic. Angiotensin constricts the efferent. Right, so these are both mnemonics of their own that are in the book. And oftentimes you get questions about whether it's NSAIDs or angiotensin 2 inhibiting things like that, stopping stuff like that. And those things are all listed out here and what their effects are. When I did this renal video, I talked about this a lot because it was really important to make sure you can understand how these things are occurring, right? How these things are occurring. So GFR, you can see the places where it increases. Take a look at where it increases. If you constrict the exit, if you decrease any plasma protein concentration, right? And then of course these two guys, afferent arterial dilation, more is coming in, and then AMP, which also dilates afferent and constricts efferent. Right? So you can see the only way to increase GFR is to make this bigger and make this smaller. Okay, and that's really important to make sure you remember. Right, so really important to make sure you remember that, because this obviously gets tested pretty widely. As far as the renal plasma flow is concerned, renal plasma flow, you can see only increases in this one scenario here, which is afferent arterial dilation. Right, that's what we're doing for our patient. But in our patient, the afferent arteriole has already been kind of compressed. This is already compressed. Dilating it would just normalize it, and that's what this question was about. Right, so you had to kind of combine the fact that this is already compressed, and then if you decrease the pressure on it, it'll kind of dilate a little more, and that'll be it. Now, this concept of autoregulation is discussed in cardiovascular, right here. And so you have your autoregulation, how blood flow to an organ remains constant over a wide range of perfusion pressures. In our patient, the kidney perfusion pressure is decreased. So there's two ways of managing that, either myogenic or tubulo-glomerular feedback. We all kind of know about the tubulo-glomerular feedback stuff pretty well. Tubulo-glomerular feedback stuff is relevant to your renin and angiotensin and all the stuff from the JG apparatus and all of that. The myogenic stuff is the other one, right? So I talked about it here for the kidneys. There are myogenic tubulo-glomerular feedback mechanisms. For the kidney, the myogenic mechanism is where the afferent arteriole controls blood flow purely based off of blood pressure entering the kidney. Right? The tubulo-glomerular feedback mechanism involves the JG apparatus and signaling from all kinds of different guys, ATP, adenosine, NO, and those guys are what we usually see on a daily basis, especially with medications that we take. Our patient has decreased blood entering the renal artery as it is. They mentioned autoregulation to preserve GFR and RPF. So you have to constrict either the arteriole. So if you constrict either arteriole, you will alter the GFR and RPF. So you can delete choices D and E, right? Increasing the pressure. You don't want to constrict anything. There's no reason to. So choices D and E can go away as soon as you read them. Choices A, B, and C are causing vasodilation, and that might help. Afferent arterial dilation, usually caused by prostaglandins, increases GFR and RPF, but since this patient already has reduced perfusion there, it'll just normalize it. So GFR and RPF will remain unchanged, right? And that's basically all this question was about. Number 9 over here, a male newborn is delivered in the hospital at 40 weeks gestation to a 31-year-old premagravid woman following an uncomplicated spontaneous vaginal delivery. It's a huge question, but it was actually a pretty straightforward, easy question. The mother immigrated from Brazil at 20 weeks gestation. So when she got pregnant, she was still in Brazil. At 8 weeks gestation, she was evaluated because of a 1-month history of low-grade fever. So maybe she got that infection when she was 8 weeks pregnant. She also had marked fatigue and diffuse lymphadenopathy. Her symptoms resolved spontaneously and she received no treatment. At that time, test results for Epstein-Barr virus and CMV were both negative. The mother's only medication was a prenatal vitamin. The newborn is 33 centimeters, so 25th percentile, it's not too bad. Weighs 5 pounds 6 ounces, which is 35th percentile. The head circumference is the problem here. 31 centimeters, coming in the 3rd percentile. So this baby has a really big head. Temperature is fine, pulse is 120, respirations are 18, blood pressure is low. Eye examination shows chorioretinitis. CT scan of the head shows hydrocephalus and cranial calcifications. As soon as you see that, a newborn baby being born with chorioretinitis, hydrocephalus, and cranial calcifications is a baby that has a problem with toxoplasma, right? The pregnant woman having an infection, especially in another country, must have been something relevant to her playing with either cat feces, cat litter, or her ingesting food that had the toxoplasma in it. Now, this is a pretty high yield bug, Toxoplasma gondii. Right now, the mother is fine. The baby has the clear triad of chorioretinitis, hydrocephalus, and intracranial calcifications. In the USA, UWorld made it very clear to understand this stuff. In the USA, ingestion of undercooked pork is the most likely answer choice. Right? Even if they have the other answer choice also, where the other answer choice might be something like, oh, she must have worked with cat litter or played with cat feces or something. It's less likely to be that, and it's more likely of ingestion of undercooked pork. Oocysts in the cat feces are dangerous, so pregnant women usually avoid cat litter. But even if contact with cat litter is an answer choice, cysts in meat is the most common route of infection and more likely. And that one URL question actually had both answer choices in it. Alright, so that's your Toxoplasma gondii right here. Right, cysts in meat, most common. Oocysts in cat feces are the other thing, but very unlikely answer choice to pick. This can cross the placenta, so pregnant women should always avoid cats. Right? It caused almost no problems to her because she, again, is not immunocompromised. Right? So she is immunocompetent, so she had some sort of mono-type symptoms, which is why they tested her for EBV and CMV, but she didn't have any of that, right? So she would have a negative heterophile antibody test or a positive heterophile antibody test. For EBV would be positive, but for our patient it was negative. That being said, it was definitely not causing a big problem in her, but in the baby, right? Congenital toxoplasma, the baby got super messed up because of that cat, and that's what this question was about. You want to make sure you get this down. Now, for me, it wasn't so bad, but I did do a revision of Sketchy Micro when I was annotating my book, and it really helped, right? Sketchy Micro has this image right here where they have all this stuff with cats, and the mother obviously picking up cat poop here, right? What really helps though is the cats that have the symptoms, right? So this one here with the calcifications, the milk on the head, right? This one also with the turban. All of these cats are kind of giving away what's wrong. The 100 is for the CD4 count, where immunocompromised individuals, such as an AIDS patient, can have bigger problems. They can have ring-enhancing lesions on MRI, and that would be a different question also on Toxoplasma gondii, right? But not what our patient is going through. So looking at all your answer choices, they were nice enough to not put cat litter as well. Cat litter is usually an immediate pick. You would just see it, and instinctively you might be like, well, that has to be it, and you pick it. Usually the trick answer. That's not the answer you want to pick. So this was just B. Number 10 here, a 53-year-old woman comes to the physician because of a 2-week history of fainting precipitated by exercise and intermittent substernal chest pain that is relieved by rest. Her blood pressure is perfectly fine, right? Ideal as heck, 120/80. Cardiac exam shows a prominent left ventricular pulse. A late peaking, harsh mid-systolic murmur is heard, best at the second right intercostal space with radiation to the carotid arteries, bilaterally. And that should be a giveaway for what's wrong with her. An ECG shows evidence of left ventricular hypertrophy. Angiography shows no coronary artery lesions, so the patient doesn't have CAD. What is the best explanation for the syncope? So the sound that they told you, harsh mid-systolic. So mid-systolic, systole is pumping. So mid-systolic murmur, and it's super harsh. That means that since it's systolic, your ventricles must be contracting, and blood is now going through the aortic valve, right? So that has to be aortic stenosis. Why is it aortic stenosis? Because this patient has blood that is radiating into the carotid arteries bilaterally, right? So as soon as it's coming up the aortic valve into the aorta, it's coming up with extreme pressure because the aortic valve is so hard to open. It took a lot of pressure to build up, and then it finally opened and blood just bursted out like a water gun. Right? So it comes up with radiation into the carotid arteries, of course, to both sides from the aorta, the ascending aorta, and that's what you're seeing here. And of course, on top of that, the patient has ventricular hypertrophy because the ventricles are getting very, very strong the more they're trying to pump blood into the carotid arteries, into the aorta. Looking at the answer choices, they put a bunch of stuff here that was there to kind of try to confuse you, but it shouldn't. What is this patient's problem? So the problem in aortic stenosis is, since it takes a really high pressure to open the aortic valve, as soon as pressure falls down a little bit, the aortic valve closes, and you still have blood left in the left ventricle that did not come out. That is your decreased cardiac output, right? Cardiac output usually decreases in aortic stenosis because you couldn't get all the blood out of the left ventricle. That is basically going to be equivalent to answer choice C, your fixed cardiac output in spite of increased demand, right? Because either you have decreased cardiac output or increased demand, they're both the same thing. You need to meet the demand. This patient is only feeling symptoms during exercise, and that's because during any kind of strenuous activity you need more blood and she's unable to get it. Right? So she has a fixed cardiac output in spite of increased demand. You can't get more blood out because you're unable to pump it out. Right? So that's the main thing there. Man, some people are so weird. Alright, so that's basically all that happened in this question. Now, the other answer choices in this question were pretty easy to knock out too. You want to remember the mnemonic D arms. Diastolic is aortic regurgitation and mitral stenosis, and those are never the correct answers, so that's not happening here. Mitral valve prolapse is also systolic, but it doesn't present with a murmur that has carotid artery stuff involved, so that's irrelevant. Mitral valve prolapse would have more of like a click or something, so that's not going to work. Coronary artery spasm would also be wrong here because this patient's substernal chest pain is relieved by rest, which means this is stable angina. Coronary artery spasm is not stable angina, right? There was no vasopressor induced hypotension happening here. They didn't mention that the patient is taking any vasopressors. If the patient was taking some blood pressure medications of any kind, that could be a possibility, but this isn't that, right? This is not vasopressor-induced hypotension. Would basically be orthostatic hypotension after starting a medication for blood pressure, but that's not what's happening to this patient. Yeah, hi Rita. I saw your message in the beginning too. I can tell you all of that about the pathology memorization for cancer metastasis. Just shoot me an email because I don't want to spend time in this video doing that. And then the other question about visa restrictions for IMGs and all of that stuff is also another video. So I can't really talk about that in this video right now because this is just going to be the NBME stuff. But yeah, feel free to shoot me an email. I definitely want to plan on making a new video about the new updates that are happening regarding COVID right now, because there's a bunch of stuff USMLE mentioned about whether doing telemedicine CS exams or doing step 1 exams inside of medical schools, both of which sound ridiculously impossible. So, I'm not sure what USMLE, ECFMG, and Prometric are doing, but just like the rest of things America is handling very incorrectly and inadequately, I'm pretty sure they're going to handle this very trashy as well. So things are not going to get any better. I don't see it getting any better. Number 11, 47-year-old man comes to the physician because of abdominal enlargement and rectal bleeding for 3 days. He drinks 12-ounce cans of beer daily. So that's a lot of beer. That's 144 ounces of beer daily. 12 cans, right? Physical exam shows scleral icterus and bleeding internal hemorrhoids. Increased pressure in which of the following veins is the most likely cause of hemorrhoids in this patient? A very straightforward question about internal hemorrhoids. So internal hemorrhoids versus external hemorrhoids are all determined by the pectinate line, right? And if we go back to first aid, just take a quick look at it. Page 401. Right here. So look at this. So you have internal hemorrhoids that are up here, inside, and then external hemorrhoids that are outside, right? This is really easy to memorize when it comes to the veins, the arteries, any of that stuff. Everything above the pectinate line is superior, right? Above is superior. So you have above the pectinate line superior rectal vein and superior rectal artery. The superior rectal vein is something that drains blood back to the portal vein. So it's very important when it comes to things related to portal hypertension, right? So superior rectal vein. Inferior, anything that is an external hemorrhoid is below the pectinate line, and below the pectinate line is inferior stuff. So you have your inferior rectal vein, which goes and drains blood into the inferior vena cava, right? Very easy to remember that. If you can remember below the pectinate line is inferior, then you also remember inferior vena cava, and you're done with that. Above the pectinal line is superior stuff, and since the below one was going to the inferior vena cava, the above one must be going to the portal vein. And that's relevant because portal vein thrombosis, portal vein tension, all of that stuff. Everything down here is inferior. Look at the inferior nerve. This is also inferior rectal nerve of the pudendal nerve, right? Whereas in here, this is autonomic, which is why you don't have any pain. Internal hemorrhoids are painless. There's no pain. But external is basically touching your butt, and if you get a needle poking your butt, that's going to hurt. So this is all actually somatic innervation. This is your normal skin over here, and it hurts. It hurts a lot, right? So for our question, the answer choices are very easy. You see inferior rectal vein, middle rectal vein, and superior rectal vein, but this is an internal hemorrhoid, which is above the pectinal lines. Above is superior rectal vein, and you're done, right? No reason to get this question wrong. So if you did, then make sure you now know this information so you never get a question about these things wrong, right? All of these veins and nerves and arteries related to the hemorrhoids, related to the GIT. GIT is a lot of anatomy, right? A lot of blood anatomy, all the arteries, veins, mainly the veins, right? The arteries are responsible for celiac, superior, and mesenteric arteries of the intestinal area. But then the veins are a huge deal because you have your veins that are the normal veins with the inferior vena cava, and you have your entire portal system of veins, which is a whole different world with the liver. It's a very, very intricate system over there. This was a great question, very straightforward. Screening test for colon cancer is done in 86 patients with colon cancer and 124 who do not have colon cancer. Results are shown, and the results are presented in ideal manner. Right? So what ideal manner is that this is plus plus, and this is minus minus, so they kept it just the way it should be. Of course, test writers can switch it around to mess up your presentation. So make sure you have the correct stuff, right? So plus plus means it's true positive right here, right? This is true positive, minus minus. This one is true negative, stuff like that. You want to make sure you have it in the correct format, right? So they gave it to you in the correct format, and then they were very straightforward. All they wanted to know was the specificity. What is the specificity? Specificity is tested with this, right? True negative over true negative plus false positive. Very easy to memorize. These equations are not only supposed to be on the cheat sheet that you can email me to get at any time, but when you look at the equations in itself, right? There's a very cool thing that occurs. So let's take a look at the equations. 268. So if you look at the equations, they did a good job kind of highlighting it. And I also added some things here and there, so you can see how in sensitivity you have an N here, and that N is your N here. There's only one N. Sensitivity is the one that has false negative in the denominator. In specificity, you use false positive, right? So oftentimes other questions on NBME, UWorld, or Step 1 can be bringing up the 1 minus false negative rate, or 1 minus false positive rate, right? And these make sense because remember how you break up an equation, right? If you were to break up this, right? So this is basically, if you rewrite it just for better presentation, it looks like this. TP plus Fn, right? Now, remember that this you cannot break up into two fractions. You cannot break up a denominator into two fractions. But what's generally happening after you do all the extra math and whatnot is that TP over TP is kind of the 1, and then the false negative rate is how much of your negatives were false, right? So it's a lot of math it takes to kind of break this up into two fractions, but it can be done. But you can't break it up into TP over TP plus TP over Fn. That would be incorrect math. But you want to make sure you memorize this stuff very strategically, not by repetition or whatever. I mean, generally speaking, do what works best for you. But you want to make sure you have all of this down because these are questions that are giveaways. It's just straight up math. There's no excessive thinking involved, especially in the question we have right here in NBME 24. So you don't want to forget the equations or forget the other presentations of the same equations. So it's just plug and chug. You plug the numbers in, you get your C, 95%, and you're done. Nothing insane. This was also a very straightforward and easy biostats question. So clinical study is designed to evaluate the association of caffeine consumption and pancreatic cancer. In the study, the alpha, which is type 1 error related, is 0.05. and the beta is 0.1, which is type 2 error related. Which of the following best describes the likelihood of missing an association between caffeine consumption and pancreatic cancer in this study? Missing an association. So basically they're asking you, where can you say there's no association even though there is? That is a type 2 error, right? That's a type 2 error. So of course they put all the answer choices that are relevant. So answer choices that are not relevant are C, basically just C, but we could say C and E. A and B are relevant because those are the numbers that they gave you, right? And then D is relevant because D is power, right? Power is 1 minus beta, which is 1 minus 0.1, so that would be 0.9, 90%, right? But our question was simply asking you, what is the chances of type 2 error? And type 2 error is your beta value, so 10%. That's it, nothing else to it. So we come back right here, right? So you have your incorrect results. You have type 1 error and type 2. Type 1 error is a false positive error, right? It's the alpha error where you accused an innocent man. So here you basically said that there is an effect even though no effect exists, right? You're calling somebody a criminal even though they are not a criminal, right? And that's bad. So in our example, you would be calling caffeine the criminal that caused pancreatic cancer even though it did not. The chances of doing that kind of mistake was 5%. They're asking you about the other type of mistake, which is type 2 error, saying that somebody is innocent even though they are not, right? So blindly letting the guilty man go free. This is a false negative. You said it's negative, but it's not. It's actually positive, right? That's a false negative. So that's what they're asking you. Missing an association. There is an association, but you missed it, okay? So in that case scenario, you want to make sure that you remember that's just beta. Power is a different thing. So that's where answer choice D comes in. Power is 1 minus beta, and that's just your way of making the results look better, right? It's all about making the results look better. You can increase your sample size, increase your expected size of effect, or increase the precision of how good your measurement tools are. But that was a whole different thing. This was just a straight question about beta. So you have to remember what alpha is, what is beta, right? And there's many ways of memorizing it. Do what works for you. I like what the book has. Accusing an innocent man or blindly letting the guilty man go free is a great way of associating what each type of error is. Stating that there is an effect when none exists is very... both of these errors are actually very bad, because in both of those cases you're going to get bad results that are irrelevant, and then your clinical trial just wasted a bunch of money for no reason. Number 14 here. A 68-year-old woman comes to the emergency department 2 hours after she vomited blood. 3 weeks ago, she began pharmacotherapy after experiencing a vertebral compression fracture secondary to osteoporosis. Temperature is fine, pulse is 104, respirations are fine, blood pressure is fine, physical exam shows mild epigastric tenderness. Endoscopy shows multiple lower esophageal erosions. Which of the following medications is the most likely cause of the hematemesis? So you look at all your answer choices, you should know for the most part all of them and what they do, but this was really just a memorization of one thing. Do you know the bisphosphonates or not? Bisphosphonates have significant side effects such as esophagitis, which is why she has the hematemesis, as well as osteonecrosis of the jaw and atypical femoral stress fractures, which she also has, compression fracture of the vertebra. It's important to take this medication with a lot of water, and of course also remain upright, not lay down or go to sleep, so you don't take it at night, right after taking it. And that's the only medication that would have this presentation. Calcitonin is irrelevant. Calcium carbonate is irrelevant. Conjugated estrogens do not cause what she's having, right? Estrogen would not do all of this to her. Raloxifene is a medication that's related to breast cancer and stuff. And raloxifene is the better medication compared to tamoxifen. You can relax when you take raloxifene, right? So raloxifene is not going to be the thing. Again, sodium fluoride is also irrelevant. So they picked a bunch of things in their answer choices that were just dumb, completely irrelevant, bullshit answer choices. Alendronate was the only one worth picking, and yeah, it's a medication worth googling because you see some pretty cool images like the one I have right here. Right, so this is osteonecrosis of the jaw. Right? That really sucks. Alendronate, any dronate are all bisphosphonates. They inhibit osteoclast activity. Right? Inhibit osteoclast activity, so you stop breaking down bone. Is used for osteoporosis, hypercalcemia, Paget disease, any of these other things, osteogenesis imperfecta, but it can cause a lot of bad side effects, and you got to be careful, right? Number 15, 33-year-old woman at 34 weeks gestation. Oh, this is a really cool question. This one I only got right because of something I had learned from another UWorld question. So there's a 33-year-old woman that is at 34 weeks gestation. She has a 2 out of 6 systolic ejection murmur heard at the second intercostal space. Remainder of the physical exam is unremarkable. Nothing else is wrong. But she is pregnant and she has this murmur. Best explanation for this finding is an increase in which of the following. So what must have increased? Okay. You can immediately knock out answer choice A because that would be preeclampsia and that would present with many other things, not this. So that's not the answer. Would there be an increase in peripheral vascular resistance? Well, peripheral vascular resistance is the same thing as blood pressure. So A and B both go away. Pulmonary vascular resistance is irrelevant. She does not have pulmonary hypertension. Her pulse doesn't need to increase. So the only thing that must be high in this patient and is causing an ejection murmur is the stroke volume. There could be many reasons it's occurring. Remember that pregnant women also have more blood in them, they have more iron utilization, they have many things. But one of the important things that's very high yield on exams is dilated cardiomyopathy. And pregnancy is one of the risk factors for dilated cardiomyopathy. Everyone remembers the A, B, triple C, D mnemonic of all the things that cause dilated cardiomyopathy, but there's a lot more than just that. So that's page 331. So dilated cardiomyopathy, of course, alcohol, beriberi, coxsackie, cocaine, and chagas, and then doxorubicin. But there's also hemochromatosis, sarcoidosis, excessive thyroid hormone, and peripartum cardiomyopathy, which is what our patient might have. Okay, peripartum cardiomyopathy. This is a question. I don't know if I have the UWorld question here anywhere. No, but UWorld had a very interesting question where a woman presented with symptoms that looked like dilated cardiomyopathy, but if you couldn't think of pregnancy being one of the things that cause dilated cardiomyopathy, you won't want to pick it, and then you get it wrong. So got to make sure you remember that. So it's just a systolic murmur due to peripartum dilated cardiomyopathy. That's it. But again, the other answer choices were just all bad. You cannot pick A or B. Definitely don't want to pick C. Why would the pulse go up? Pulse increasing has nothing to do with this ejection murmur. So it must be the stroke volume. With more blood, you're having a bigger stroke volume and leading to a systolic ejection murmur, which is obviously related to the stroke, not to diastole. Nothing diastolic is happening. This was a unique kind of question as well. Very interestingly worded, but definitely doable. You don't need to know the information that's actually on this page to answer this question if you thought about it the way I did. So I read the question, 27-year-old man sustains a spinal cord transection at C8 during a skiing accident. In which of the following situations is he most likely to be able to achieve and sustain an erection? So they specifically said that C8 is not working. C8 is not working. So C8 is not working. Then you look at all your answer choices. Erotic dreams occur in the brain. Reading anything erotic occurs in the brain. And viewing erotic material also occurs up here. And since things are now working in C8, anything up here was the wrong answer to me. So I canceled out A, C, and E immediately. That left me with B and D. Penile stimulation and testosterone injections. Testosterone injections, as is done by certain people that do steroid abuse for sports, will actually mess up the penis. Will actually mess up anything sexual, get rid of the testes and all of that. So testosterone injections do not cause erection, so I went with penile stimulation. Something down there must be working correctly because something up here is definitely not working correctly. Then I found this article. I'll link it down here in the chat. Physiology of an erection. So physiology of an erection involves cerebral control, autonomic control, and molecular mechanisms. They're not so hard to understand. The cerebral control erections are induced by erotic visual stimuli or thoughts, which is related to choices A, C, and E. there's something called the medial preoptic nuclei, which I remember as the medial penis nuclei, and it's medial because the penis is medial, right? So medial preoptic nuclei, as well as the paraventricular nuclei, those guys of the hypothalamus utilize dopamine to help cause erections through other signals, not just dopamine directly causing erections, but through other signals. Autonomic control is through the parasympathetic stimulation and central suppression of the sympathetic nervous system. Remember, all of this stuff is parasympathetic. It's rest and digest. Rest and digest is related to sex, not the sympathetic stuff, which is for fighting and evading and whatnot. So you need parasympathetic stimulation, but you also need sympathetic suppression, right? Which is why people that are stressed, people that are depressed, people that are in some kind of anxiety, they cannot have an erection because of that sympathetic overpowering. Autonomic control is parasympathetic stimulation by the sacral S2 to S4, right? The pelvic splanchnic nerves and sacral splanchnic nerves and all of those guys that are listed in this picture. Pelvic autonomic nerves. Those nerves can actually cause erection through tactile penile stimulation. When both of these things work together, cerebral and autonomic control, the erection is optimal. Now, patients with a lesion above T9 cannot maintain a psychogenic erection because central suppression to the sympathetic stimulation is necessary for that. Right? If you have a lesion in T9, you will not be able to get your sympathetic suppression, right? Sympathetic suppression of the system to actually get an erection. Patients with sacral spinal cord injuries can get a psychogenic erection, which is the opposite case scenario what's in our question, but that erection would be weaker than normal, right? So really interesting stuff here. Molecular control is one we all know about, using Viagra and NO, not testosterone. Testosterone doesn't cause erections. Testosterone causes actual bone mass and muscle mass and stuff like that. So very interesting question, right? But you gotta make sure you know this stuff. This is all discussed in page 689. So the page numbers that I have written, I should have mentioned this in the beginning. The page numbers I have written are 2. The first number, 612, is of actual first aid 2019. Alright, so that's the page number that's right here. And then the other one is my PDF's page number because I've added more pages into my PDF. Alright, so again, in reproductive anatomy, you talk about all these. Now you got to find all the arteries and veins and everything on your own because not all of it is in first aid. It's in my book, but it's not always there in all other resources. So, you have your internal pudendal artery, you have the deep artery, right? And that deep artery is the one that gets maximal blood flow for an erection, especially when someone takes Viagra. And I wrote that here too because that was a question somewhere. This is your U-World image showing you all of that, right? So you have to make sure you remember nerves that can get injured, especially if you're going to be doing something to the prostate, right? So you have your prostatic plexus right here. Right? Prostate surgery, stuff like that can often injure it, injure some of these nerves over here. And what happens is all explained in this question here. So feel free to pause the video and check it out when you come back later. Here is the autonomic innervation of male sexual response. Right? They talk about erection being a parasympathetic thing from the pelvic splanchnic S2 to S4. Right? And then emission is sympathetic, so that's hypogastric nerve T11 to L2, and expulsion is somatic pudendal nerve. Right? There's a bunch of different things involved in the entire act succeeding. I added notes from the question right here just now. So that question we just did, I added the physiology of an erection into this section right here, so you can put that into your book as well. And I think that was about it for this question. Very interesting question. NBME loves asking at least one question about an erection. And this is a unique way they're asking about it. Usually the questions have been about whether or not a patient is going to get an erection because of psychological issues like fighting with the wife or injury of some kind, and it's usually a weird type of question, but they kept repeating it. Now they've asked the question in this manner rather than repeating those questions from previous NBMEs. Love this question because I really loved the picture they gave here. This picture was something I've been trying to find for quite a while to put into my book because it shows you the apple core lesion. Right? So usually when we do a barium enema swallow x-ray, you would see the apple core lesion, and this is exactly what shows up as an apple core lesion. Let's take a look at what I'm talking about. So page 425, where they talk about colorectal cancer. You see your apple core lesion? This is the apple core. The core of an apple after you're done eating the whole apple. That is what's showing up, right? So this section is what's showing up like that. Okay? And that's what they're showing you in this amazing gross image of someone who has colorectal cancer without polyps. There's no polyps. 40-year-old man comes to the physician because of a 6-month history of constipation and weakness. Obviously, the constipation is occurring because feces will not be able to pass here. He has a family history of colorectal carcinoma in multiple family members of both sexes. Physical exam shows no abnormalities. Lab studies show hemoglobin of 10, hematocrit of 32, MCV of 73. Colonoscopy is done, and just this lesion is found. They didn't mention any polyps, nor do I see any polyps in this picture. Photograph is shown, subsequent colectomy, right? Analysis shows mutation, and this is a typo. So they in the test wrote MHS2, but they meant to write MSH2. Either way, it connects the link. This is HNPCC. It's Lynch syndrome, right? Lynch syndrome. So you come back to here. Lynch syndrome, you have the 3-2-1 rule. 3 relatives across 2 generations, where one of them is under age 50, and that's our patient. Our patient is under age 50. This is a very young age for this man to have colorectal cancer. And it's due to many kinds of genes, right? The UWorld has questions where they mentioned MSH2, MLH1, MSH6, PMS2, a bunch of different genes that are associated. The main thing is no polyps are noted, right? This is HNPCC, NP, non-polyposis, right? It's due to autosomal dominant mutation of DNA mismatch repair, so MMR, right? Mismatch repair with subsequent microsatellite instability. And that's a really big deal. That's different from the usual molecular pathogenesis, right? The usual molecular pathogenesis is with the chromosomal instability, mutations in APC, KRAS, TP53, and then eventual progression of colorectal cancer. Very important to make sure you spend time mastering this stuff, get it down well. It's going to be on your test, right? Very high yield topic. All the other answer choices did not really make much sense for this. You would not pick, for example, FAP, familial adenomatous polyposis, would have polyps, right? That would make no sense. NF1 is irrelevant here. Leaf romanines or dermal are irrelevant. They're all, you have to know the disease to be able to figure out it's irrelevant. So if you don't know any of these diseases, make sure you Google them, check them out, know what they do. All right, this is a beautiful picture showing you the apple core lesion. 18, a 22-year-old woman comes to the physician because of nausea and vomiting for 1 week. She has a 6-month history of headaches. She works as a data entry technician and has recently found it difficult to focus on the text. She also had trouble looking up from her desk at the clock on the wall without moving her head. Neurologic exam shows marked vertical gaze palsy and impaired accommodation. So she doesn't accommodate, right? And that's very much like stuff that occurs in syphilis. Horizontal gaze is normal. MRI of the brain is most likely to show a tumor at which of the following locations. So it's related to a tumor. Now, vertical gaze palsy associated with the tumor is an immediate giveaway for Parinaud syndrome, that's pineal gland done. Right, this patient is presenting with Parinaud syndrome, which has a vertical gaze palsy due to compression of the tectum. This patient most likely has a pinealoma. This is a very straightforward and simple question. In males, this question can present even more complicated. They can be like, what would you find elevated in this patient? And then the answer choice is HCG, but you might not pick it because we all associate HCG with just a positive sign of pregnancy. But, excuse me. See, my mouth is getting dry now. But what you need to remember is that a pinealoma is very similar to a germ cell tumor like seminoma, and that's where the HCG connection comes in, right? So, pretty simple question, very unique, so there's no confusion between other differentials, and totally doable. Let's take a look at that real quick. Pinealoma, right? Tumor of the pineal gland causes Parinaud syndrome. It is going to cause compression of the tectum, and that's what causes vertical gaze palsy, right? And one of the things that's very important, you can see in this patient, this image shows a patient with left vertical gaze palsy, the left eye. It's instead of his pupil actually moving up, only the eyelid is retracting, and that's known as the Collier sign. And that's another thing that can be tossed into questions, right? Eyelid retraction. Instead of me moving my actual pupil up, only my eyelid is moving up because my body is, my head, my face is trying so hard to actually look up, but I can't. The only way I can look up is by moving my entire head to look up, right? And that's not normal. That's not how it's supposed to go. Number 19, very annoying type of question that I'm sure a lot of you guys hated, but these things are stuff you want to start feeling comfortable with, right? You got to get comfortable with things you're not comfortable with. You must. If you have trouble with it and you leave it as something you're not comfortable with, you're going to continue getting it wrong. In the study of antibiotic resistance, a strain of E. coli that is resistant to ampicillin but sensitive to streptomycin is cultured with a strain of salmonella that is sensitive to ampicillin but resistant to streptomycin. So both of them are resistant to different antibiotics. 4 hours of cultivating them together, the broth is plated onto solid medium containing both ampicillin and streptomycin. Soon enough, some of the salmonella are resistant to both antibiotics. Which of the following is most likely mechanism of acquisition of ampicillin resistance by S. enteritidis? I call this survival of the fittest, which it clearly is, and survival of the fittest is a result of mating, right? When two people give birth to a new child, that child is better than both of the previous two people, depending on the genes that were passed. That child could also be worse than both people, depending on the genes that were passed. If you gave two bad autosomal recessive genes and caused sickle cell in your child, that sucks, right? So either way, the resultant person, if they're significantly different than both of the people, is because genes were passed. And the only answer choice that passes genes from one to the other is conjugation. That's it. What is the difference between all of these different guys? You want to make sure you spend time, do it one day and then come back and revise it another day to truly master it. You want to make sure you get all the bacterial genetics because these are also giveaway questions. Now, something that was new for many people was the fact that bacteria that are different from each other are practically having sex with each other, and that's because they can. It's not real sex, it's just passing genes. Right? So you have your E. coli and salmonella passing genes from each other, right? And that's what you're seeing here. So conjugation, as you could see, is one bacteria and another bacteria giving things to it. Notice in our question, E. coli and salmonella were grown together, but only the salmonella gained both things, right? The salmonella gained resistance to both antibiotics. And that's what you're seeing here. Imagine this plasmid is what has the thing you need for ampicillin resistance, right? So let's say this one over here on the left is your E. coli. The guy on the right is your salmonella, right? E. coli has the plasmid that's resistance to ampicillin. This guy, in his own genes, has resistance to streptomycin. If this ampicillin resistance gene is given to the other guy, now salmonella is resistant to both. But E. coli is still sensitive to streptomycin, right? As you can see from our question. So E. coli, nothing changed. And you can see that from beginning to end in these images, right? E. coli, which I'm calling it is this guy, looks the same. Nothing changed for this one. Right? Nothing changed for this one. For the other one, though, which I'm denoting the F-1 as salmonella, salmonella now has both resistances. Right? That occurs through conjugation. You passing a gene through the, what I could call the F factor, or the fuck factor, right? It is the F factor, but I remembered it as the fuck factor. Is the guy that gives things, right? So the E. coli must have been the one that had F positivity. It was able to give it to the other one, right? And after that, they both become F positive, right? So one critical thing, the first one didn't change at all. Other critical thing, genes were passed from one bacteria to another. That only occurs in conjugation. You cannot pick any transduction because transduction would have been a virus bringing genes, okay? Transformation, as you can see, is only involving one guy. One guy, no one else. Competent bacteria bind and import short pieces of environmental naked DNA, and then they become more adept. And this is most important for the Shin guys. That is not what occurred in our question scenario. This is also, transposition is also not what occurred in our guide. This is also something that occurs within the same one bacteria, not two different bacteria sharing anything. right? So very, very easy. So you knock out transduction because it's not a virus. You knock out transposition because it's two different bacteria doing things with each other, and that's conjugation. They're basically having sex with each other, right? So don't get stuff like this wrong. Just make sure you get it. Point mutation and gene duplication were completely irrelevant filler answer choices. Number 20, a 15-month-old boy is brought to the physician by his mother because of a 9-month history of recurrent bacterial infections. So it looks like an immunology question. Patient has not had recurrent viral infections. So that gives away a lot, right? What causes bacterial infections? What causes viral infections? You want to make sure you know that in terms of immunology. He's at the 10th percentile for length and weight, which is not so good. Physical exam shows multiple areas of honey yellow crusted lesions, which looks like Staph aureus. Gram stain of one of the lesions shows many gram-positive cocci. Lab studies show no abnormalities except for a leukocyte count at 30,000, right? So he's still getting bacterial infections. The patient is most likely to have a rare autosomal recessive disease leading to a lack of CD18 expression. So they gave you a very specific diagnosis. Leukocytes would be deficient in which of the following characteristics? So what is the CD18 stuff for? You have to make sure you remember leukocyte adhesion deficiency, type 1. Right, so page 117 over here gives it away. So remember, what causes bacteria, what causes your viral infections. So look at all your B cell disorders. B cell disorders mainly, right, if you don't have your B cells, you're going to get a lot of bacterial stuff. Bronchiectasis, sinopulmonary, all these bacterial things that are occurring. Recurrent bacterial. Right? And then there's enteroviral infections because you need B cells for that too. If you have a T cell disorder, right? If you have a T cell disorder, notice that it's not just about infections, it's a bunch of other things that are going wrong too throughout the body. Right? Baby teeth, abscesses, blah, 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 all kinds of other stuff. And then of course candida, right? Skin and viral and all of that stuff. Very weird. Right? Now for our guy, they said recurrent bacterial infections. We saw the skin infection, they mentioned it already. And then, of course, stuff they didn't mention was all of this stuff, but they gave you this, the CD18. That's a giveaway. CD18 is a subunit of the beta-2 integrin, which is responsible for migration and chemotaxis. Okay, without it, you would have no migration, no chemotaxis. So other things that could be given in such a question is the absence of pus, impaired wound healing, and of course, the delayed separation of umbilical cord. They almost never mention the delayed separation of umbilical cord anymore because that's something that everyone kind of pathognomically remembers for LAD type 1. So this is the good presentation itself too for the same thing. That would be answer choice E, migration. Clearly this patient has leukocytes. They're just not getting to where the disease is. They're not getting to the infection. Right, so that's it. No recurrent viral infections basically meant that the B and T cells are doing their job kind of okay. Right? B and T cells are doing their job kind of okay. And that was very critical too. Right? It's not a bad question at all. Just make sure you understand the various differences between all of these disorders in the immunology section. All the immunodeficiencies. Very high yield stuff. This was okay. This one, I didn't dislike any of the first 25 questions I did. I think they were all pretty good, straightforward, and I didn't get any of them wrong either. A 10-year-old girl is brought to the physician by her mother because of increased hair growth on her face and increased muscle mass during the past 3 months. Breast development is very bad, Tanner stage 1, and pubic hair development is Tanner stage 5, which is way too far ahead. Physical exam shows clitoromegaly. Pelvic exam shows a normal appearing vagina. Serum studies show testosterone is super high. The rest of it being not so significant, right? LH is low. Okay, but testosterone is 14, which is way too high. An unregulated increase in hormone production by which of the following types of cells is most likely cause of this patient's hirsutism. So in this question, those answer choices are really just there to test how new you are to medical prep, because if you've been studying for step 1, you know what all those guys do. Zona fasciculata is for cortisol, zona glomerulosa is for aldosterone, your pituitary acidophils, right? You have your flat pig. The pig stuff was acidophils, prolactin and growth hormone. Basophils are all your FSH, LH, ACTH, TSH, right? All of those are irrelevant, so you cancel out all of that, leaving you with C and D. Is there something wrong with the ovarian follicles, or is there something with ovarian Sertoli Leydig cells? Ovarian follicles are just going to come out in the period. So That was not the correct answer. The answer was just an ovarian Sertoli Leydig cell tumor. She has a Sertoli Leydig cell tumor that resembles testicular histology and produces androgens, leading to virilization. The patient's presentation is classic for this tumor, and that's it. There's really nothing else to it. If you don't remember it though, if you don't remember Sertoli Leydig cell tumors, that's okay, because you can still cancel out all these other answer choices that are just far too irrelevant. This is not a congenital adrenal hyperplasia. This has nothing to do with a pituitary adenoma of any kind. It's just answer choice D. Alright, so 711. So right here you can see your sex core stromal tumors that are benign. There's the fibrous tribroma, right, with a triad of fibroma, ascites, and pleural effusion. You get a pulling sensation in the groin. Spindle cells are going to be found. Very good giveaway for the answer. Spindle cells. That's a fibroma. Very straightforward. Sertoli Leydig cell makes androgens causing virilization. Right? Yellow-brown mass. And it looks like, what do you call it? The histology is going to resemble testicular stuff. Yeah, so, pretty doable stuff. A thecoma makes estrogen. All that's going to cause estrogen. Remember, estrogen is going to cause abnormal uterine bleeding. Anytime there's excessive estrogen, there's a chance of abnormal uterine bleeding. There's a chance of the reason it occurs is because progesterone is what stops the bleeding. You keep your uterus good and ready for gestation, whereas estrogen is abortive. You're going to get rid of it, so uterine bleeding occurs. Right? Memorizing these guys is not so bad. All your ovarian neoplasms, of course, malignant versus benign, but you have to, for me it was writing it out on like a chart of my own, piece of paper, actually writing it, looking at it, talking about it in my head without the book in front of me, and then it would just stick to me at some point, because all of these guys are pretty unique. There's a bunch of stuff, like this germinoma is pretty cool because in here you again have a CG elevation, right? So it's not because the patient is pregnant, it's because the patient has dysgerminoma, right? So you got to make sure you get that stuff right. An immature teratoma is very aggressive compared to a mature teratoma, which, mature cystic teratoma, which is just fine. This is benign, right? But the immature teratoma is really bad, right? Commonly diagnosed before age 20, gonna have a bunch of embryonic-like neural tissue, and you just gotta do surgery. The yolk sac tumor has a Schiller-Duval bodies that look like glomeruli. And all of this is stuff you just gotta memorize by repeatedly looking at it and talking about it in your head. 22, a 45-year-old man is brought to the emergency department 2 hours after the sudden onset of severe pain in the left flank that awakened him from sleep. Okay. Reports that the pain moved over the next 30 minutes to the left lower abdomen and now is principally localized in the scrotum. Pretty good giveaway for what's happening here. Physical exam shows no palpable masses in the abdomen or the scrotum, no rebound tenderness. Which of the following is the most likely cause? It looks like something's traveling down the ureter. Alright, so that's got to be answer choice D. Renal calculi, a stone in the left ureter. The pain was of sudden onset. It started in the left flank, moved down to the scrotal area because now it's probably reached the penis. And there's no palpable masses in the abdomen or scrotum, so that rules out any tumors over there. No rebound tenderness rules out anything related to the appendix, like your appendicitis. This is just a classic loin to groin pain. Loin being this area right here, right, and groin being the crotch area, and that's because of nephrolithiasis. Right, nothing insane in this question. Of course, they're trying to be cool and tricky with it, but very easy and straightforward. This was also just another trick question. So, 38-year-old woman, G4P4, comes to the physician because of a 6-month history of urinary incontinence when sneezing and coughing. So if coughing is causing leakage, that is a stress incontinence. Physical exam shows normal appearing female external genitalia. When the patient is asked to perform a Valsalva maneuver, leakage of urine from the urethra is detected, which confirms the stress incontinence. She is given instructions to perform Kegel exercises to strengthen the muscles of the perineum. Which of the following muscles in this patient is most likely to remain unaffected by the exercises? So which of these guys are not going to be affected by Kegel exercises? So you read all of them: bulbospongiosis, transverse perineal muscles, external urethral sphincter, internal anal sphincter, and ischiocavernosus. The only answer choice that's different, remember, logic, I've talked about this in all my NBME questions, if you do a logic test, oftentimes you get questions where they're like, which one of these is different from the others? And then you have to pick the one that's most different from the others. Here, answer choice D is most different from the others. We were talking about all these muscles that are most likely related to the urethral area, and then all of a sudden we're looking at internal anal sphincter, which has nothing to do with urination, right? So doing Kegel exercises will make many muscles stronger because it is an exercise, but the muscles that will make stronger are all striated muscles. They're muscles that you can actually control, so you can control when you go to the bathroom. The internal anal sphincter is not a muscle you can control. It's under autonomous control. It is a smooth muscle. So working out and doing exercises of any kind will not have any effect on that. And that's all this was about. The external anal sphincter, however, if they had that as an answer choice, then that would not be an answer you would pick. External anal sphincter is under pudendal nerve control, and it would strengthen from exercise. And you can always remember that because patients who get pudendal nerve anesthesia during delivery to do a cut to make the opening bigger will actually oftentimes during delivery poop. And that's a very common thing. Many women during delivery can often end up also defecating because they can't stop it. They have no control on it. And that's also a reason why many pregnant women on the day they're about to deliver try to take laxatives to poop way before their delivery hour comes. Right? So very significant thing right there. Last two questions for this video is number 24. This was a doable question only because of the way the answer choices are. So 1 week old newborn is brought to the physician because of poor feeding, vomiting, and lethargy during the past 4 days. Patient was born at term, pregnancy and labor were perfectly fine, no congenital anomalies. She's being breastfed, which is also great. She has a healthy 2-year-old brother, a sister that died at the age of 10 days after full term, and that's it. Physical exam shows decreased muscle tone and poor responsiveness. Reflexes are also normal. Her serum bicarb is 8, pH is 7.15, and plasma ammonia concentration is 10. Which of the following is the most likely cause? Right? So it looks like the baby is not having much energy, right? Poor feeding, vomiting, progressive lethargy, bicarb and pH. pH is really low, bicarb is really low here too, so that's some level of ketoacidosis, it seems like, right? And then the hyperammonemia, plasma ammonia 10 times above, so ketoacidosis and hyperammonemia. So you immediately start thinking, when you look at hyperammonemia for a metabolism question of biochemistry, you think of urea cycle. Urea cycle might make you think of the U in hug, right, where the enzymes are both mitochondrial and non-mitochondrial, and then you might see answer choice A, and you immediately pick that this is a mitochondrial disorder, and that will be wrong, right? And I'm sure many people fell for that because that's why mitochondrial disorder is answer choice A. But they told you that the brother is fine, right? So when you see mitochondrial disorder, you want to think of something that's passed mitochondrially in terms of genetics, and of course all the brothers would get it. So this is most likely not a mitochondrial disorder. Now what would really help is if you started using First Aid 2020, because in First Aid 2020 they have this disease. First Aid 2019 kind of mentioned it, but not really. So urea cycles here, right? And you can see some of these enzymes, mainly CPS1 and OTC, are inside the mitochondria. But that's not what this question is really about. Our question is actually about the organic acidemias. Alright, so in 2019 they only mentioned propionic acidemia, and in 2020 they also mentioned methylmalonic acidemia. Point is though, all of these are organic acid problems that can cause these things. Inhibit gluconeogenesis, which obviously causes more ketoacidosis, and then it inhibits urea cycle, causing hyperammonemia. And that's what our baby has. Organic acid accumulation. Either the propionate or methylmalonate is accumulating, depending on whichever disease they have, and because it's accumulating, the baby is getting hyperammonemia. Always think of that. Organic acidemia, right? Propionic or methylmalonic acidemia, because the enzyme is missing, and that is an organic acid metabolism disorder. Right? It's a metabolism disorder. A mitochondrial disorder would have many more symptoms than just what you have here, and it would probably be in many more patients, right? Many more of the family members. So, slightly fair question, not exactly the worst way to ask about it. they mentioned all the symptoms. Mainly the hyperammonemia was a giveaway for the metabolism aspect. So don't pick mitochondrial. You can't pick mitochondria because you didn't know it was definitely a urea cycle disorder. You also didn't know it was definitely ornithine transcarbamylase deficiency, any of that. Moreover, just for completeness, OTC deficiency, where they mention it, right here. OTC deficiency is an X-linked recessive disorder. X-linked recessive disorder, which means that it would have actually affected the brother, more likely to occur to the brother than, did they give the gender of this? No, she, yeah, right, than this girl. The patient is a girl, right? So OTC deficiency would have probably occurred to the brother, not this girl. It's an X-linked recessive, and girls have 2 X chromosomes. 25, last question for now. Again, coming back to biochemistry, coming back to microbiology. What NBME likes doing with microbiology is they like picking on questions that are from not bacteria and not viruses. So they like picking on nematodes, all the different carriers like the black fly and stuff. And already in these first 25 questions, we've seen 3. This is the 3rd question right now, related to something from there. This one is about Trichinella spiralis. So a 45-year-old man comes to the physician because of a 3-day history of fever and muscle pain. He recently went on a hunting expedition to North Canada, where he consumed polar bear meat. Temperature is 103.1. Physical exam shows periorbital edema and muscle tenderness. Which of the following tests is most likely to establish the diagnosis? Look at all your answer choices, and you might think muscle biopsy sounds ridiculous, but that's actually what's going to establish the diagnosis. This patient has classic symptoms of Trichinella spiralis. The nematode travels the bloodstream and enters striated muscle, and that's what he gets for hunting polar bear. That's so page 164. Trichinella. So all of these things, all your different mycology, parasitology, those things they love picking on in NBME. So Trichinella spiralis presents just like our patient did with trichinosis, the periorbital edema and myalgia. Right, very significant. That's what I'm saying. Like, you can memorize all of these guys because each one of them has something that's very unique to it that no other guy has, and then you just gotta associate it with the name. Trichinosis has periorbital edema and myalgia. Larvae will go and live in striated muscle, causing muscle inflammation. And you give the patient bendazoles, any bendazoles, and they'll be okay. But it takes time. He's already pretty messed up now. Alright, so we'll stop here for now. In the next video, I'll come back later on and continue to part 2 and finish up block 1. Thank you very much for joining, guys. Keep studying hard, and feel free to email me if you have any kind